हेलो बच्चों, आई एम डॉक्टर अंकित।
हाय, आई एम डॉक्टर मारवा।
छोटा सा ये 15 मिनट का तो तू अंदर ही रहना, ताकि हमारी आईज उधर जाएंगी ना, तो बता देना, इशारा कर देना, हम कट ले लेंगे।
अभी दो रिपीट नहीं करेंगे, कोई बात नहीं, यहीं से करते हैं आप कंटिन्यू। 1 2 3 स्टार्ट एंड वी कैन नॉट कट।
सर वो मैंने क्वेश्चन पूछा था, मैं भूल गया।
कट कर देना।
हाँ नहीं कर
बोल देते हैं
वो क्वेश्चन क्या था सर?
मेनली एज एन आईवी ड्रग इनटू अ सेंट्रल वेन बिकॉज़
को फिर से कर लें। एट्रियल फिब्रिलेशन में तो एडिनोसिन का रोल नहीं हुआ ना सर?
एसवीटी।
अच्छा सर पीएसवीटी बोलो फिर।
पीएसवीटी बोलो।
हाँ
ठीक है, 1 2 3 स्टार्ट।
इसको ना फिर से कर लेते हैं
दोबारा से।
ये बोलो।
So today we are discussing about myocardial infarction, which is also known as acute coronary syndrome. Hello बच्चों, I am Dr. Ankit.
Hi, I am Dr. Marwah.
So today we are discussing about myocardial infarction, which is also known as acute coronary syndrome.
Guys, you are aware of the fact that this happens to be one of the leading causes of death in India. So therefore, it's important that we study about the therapeutics related to this topic. Well, this condition of acute coronary syndrome would be characterized by development of a big thrombus bang in middle of the coronary artery. And this is going to contribute to a substantial amount of myocardial necrosis. Now, the point to be understood is that what is the nature of clot? Because traditionally, in medical college, we read that whenever we are dealing with a case of myocardial infarction, like ST elevation MI is a full thickness infarction, non-ST elevation MI is like a partial thickness infarction, but that does not give any therapeutic advantage to us, because that is only for our academic knowledge that we are studying, okay, ST elevation MI is full thickness, non-ST elevation MI is partial thickness. What actually matters for therapeutics is the nature of the clot that would be present. So what you need to learn as doctors first and foremost is that when it comes to ST elevation MI, guys, then this is a condition which would be characterized by a fibrin rich clot present, and that explains the fact that why in case of ST elevation MI would you be going ahead with thrombolysis. Now sir will obviously be providing inputs with respect to what are the drugs that would be used, but when it comes to non-ST elevation MI and unstable angina, then this would be platelet rich thrombus, and that is the reason why the therapeutics of the two would be slightly different. That if it's a platelet rich clot present, then there is no benefit of fibrinolysis, because medical science is all about benefit versus loss. So if I'm going to get a benefit, I will be using fibrinolysis, but when it comes to a platelet rich clot, fibrinolysis would not be done. So that is one concept regarding why are we not doing thrombolysis in non-ST elevation myocardial infarction / unstable angina, which in the current edition of the book is written as NSTACS, that is non-ST elevation acute coronary syndrome. Now the treatment of choice for ST elevation MI is obviously percutaneous coronary intervention, and even in high risk cases of non-ST elevation MI and unstable angina, we are still doing a PCI, but the time guidelines for the two would be slightly different, that we'll be explaining to you. And one of the highlight would be that in unstable angina, obviously there would be an ST depression present. For non-ST elevation MI, again ST depression would be present, but in ST elevation MI, obviously you would be having that classical Pardee sign, which I'm just going to hand draw before you. This would be the ST elevation with a convexity with a T wave inversion. But now what you need to understand is biomarkers are going to be always elevated. The MCQ will say words like rise and fall of biomarkers, or he will say like value more than 99 centile of the upper reference limit. But overall, I can say that biomarkers would be always elevated when it comes to both types of myocardial infarction. But angina, whenever you say angina, then biomarker report will always be normal. So one, we can differentiate between these presentations on the basis of combination of ECG as well as biomarkers. And ECG is obviously the first investigation to be used. But if he says like what is the best test, then the answer would be given as biomarker. Troponin I and troponin T are the preferred biomarkers. Over and above this, you can quickly comment in the chat box what other investigations can be done for diagnosis of MI. Obviously ECG can be done, biomarkers can be done, but anything else that you can be doing, well, I'm just giving you 5 seconds to think about it. What other investigations can be done? So we can be doing, I think you would have guessed it by this time, echocardiography, because we can have regional hypocontractility, or we can have a motion ball defect, and we can obviously do coronary angiography in the case also. And if we do a coronary angio, we'll be able to prove that there is a big thrombus present in the bang in the middle of the coronary artery. So like there are 4 investigations, but obviously the first one is ECG. And our primary objective is that why are we doing ECGs? Not only that we are able to identify the type of MI, the therapeutics for each one of them is also different. So we can move ahead to the management part, which sir would be explaining.
So if we talk about management and think logically, what we have to do, if a patient of MI suddenly comes to you, first give initial symptomatic treatment. Then what we have to do, we have to prevent the sudden complications of MI. But if complications has arisen, then treat those sudden complications of MI. Then do definitive treatment, which will be opening of coronary artery, which we will be discussing as reperfusion therapy. And lastly, we will send the patient back home and we will give secondary prophylaxis so that in future, another chance or another attack of MI can be prevented. So these will be the 5 management guidelines in the treatment of MI. So let's start with the first one, that is initial symptomatic treatment, and we can remember with the help of a mnemonic, MONAS. So you know that MI patient generally has a chest pain. So in MONAS, M stands for morphine. So why we give morphine? To reduce chest pain and also the sympathetic overactivity, which can lead to anxiety, apprehension, feeling of impending doom. It can also be prevented by morphine because morphine indirectly through brain reduces sympathetic discharge. Obviously, we have to give oxygen because the coronary arteries are blocked and ischemia and infarction is because of hypoxia. Then we give nitroglycerin. Nitroglycerin is basically given to reduce preload because it's a venodilator, hence it will reduce the cardiac workload. We know that in all types of MI, there is platelet-rich thrombus and hence we have to give an antiplatelet drug, aspirin. Now, last drug which we have written out here is streptokinase. Now, streptokinase and other drugs which we are going to discuss will be fibrinolytic drugs. Remember, this streptokinase is a reserved drug for only and only ST elevated MI because as we have already discussed, the fibrin-rich thrombus must be removed only and only in cases of ST elevated MI. Now, what is the chronology or in which pattern we have to give a drug? If a patient comes, first we start antiplatelet drug aspirin in the highest possible antiplatelet dose, which is 325 milligram. And we also give oxygen. So this is the first drug to be given. Then we give nitroglycerin. It is placed as a sublingual tablet, 0.5 milligram below the tongue, but it can be tried only maximum to 3 times. Then we give morphine, that is IV, 2 to 4 milligram, and a very important class of drug which must be given IV during an acute attack of MI, that is statins. Either atorvastatin 80 milligram or rosuvastatin 40 milligram. Remember, these dose of 2 statins are the highest possible dose of statin. We call them as high intensity statin therapy because it has been seen that statins, they prevent the plaque or thrombus disruption. That means they have direct anti-atherosclerotic action. And the recent trials have shown that if you give statins in high dose during sudden MI, they reduce the chance of sudden death by more than 40%. So this is the initial symptomatic management. Now the next thing we have to do is, should we give only one antiplatelet drug? Or we should combine any other antiplatelet drug with aspirin? So it has been seen with trials that we must give at least 2 antiplatelet drugs. One is aspirin and the other we can give is clopidogrel. Its brother prasugrel. So you can see they are ending with the word grel. We can also give ticagrelor. So these antiplatelet drugs, when combined with aspirin, this therapy is known as dual antiplatelet therapy because it has been seen instead of giving one drug, when we give 2 antiplatelet drugs, there are better chances of reduction in sudden mortality in MI patient. Now these are antiplatelet drug. What is the role of anticoagulant drug? So anticoagulant drugs like warfarin. And if the patient is unconscious, we can give IV heparin. So warfarin is an oral anticoagulant drug. Now generally, anticoagulant drugs don't have any role in MI because anticoagulant drugs, they prevent the deposition of fibrin. But in coronary artery, the main problem is attachment of platelets. The anticoagulant drugs are reserved only and only if the patient is having associated atrial fibrillation or ventricular fibrillation. The reason is very simple. When we see the normal contraction of heart is just like this, in fibrillation there is ineffective contraction which will lead to blood stasis. Blood stasis can lead to gradual deposition of fibrin, and this fibrin can detach from this heart and go to various organs like brain, which can lead to ischemic stroke and other complication. So if there is fibrillation, then add anticoagulant drug. Otherwise, there is no role of anticoagulant drug. So now you have stabilized the patient. Prevent the complication which can arise. So we know that in myocardial infarction, this infarct size can increase or infarct expansion can occur. Because of this reason, we have to give cardioprotective drugs. Because cardioprotective drug, they prevent this infarct expansion. And we have to remember A and B, that is ACE inhibitors, which will end with the word pril, and beta blockers like cardioselective beta blockers, atenolol and metoprolol, they prevent this infarct expansion. And again, it has been seen that during an acute attack of MI, it is mandatory to give these two drugs. They reduce the chances of sudden death drastically, more than 40%. But beta blocker has one additional use. Beta blocker also prevent arrhythmias. Because in MI, the patient has sudden sympathetic overactivity which can precipitate an attack of arrhythmia. So beta blocker has one additional use. Now imagine if a patient of MI comes to you and patient already had some acute complication, we have to manage those complications to prevent the sudden death. So we can see the treatment of sudden complication of MI if present.
Here, what I would like to add is, like, in the initial management part, we were giving nitrates to the patient. So because nitrates would be contributing to development of hypotension in a patient, so you have to be very, very careful regarding checking the blood pressure. So do not give nitrates to the patient if the systolic blood pressure is less than 90 millimeters of mercury. And what I would like to emphasize at this point of time is that whenever I talk about nitrates, you see, they would not be recommended in inferior wall MI. In fact, in any MI, they can be hypotension. Anterior wall MI, in the initial part, due to sympathomimetic stimulation, there would be a spike of blood pressure. But once the patient goes into congestive heart failure, he gets into AHF. That is like now we don't use the word ADCHF, acute decompensated congestive heart failure. So in case it's like a acute heart failure developing in a chap, then we would not be giving nitrates to the patient. So a word of caution at this moment is that always check the blood pressure and do it by yourself. Do not rely on staff, on anybody else, because sometimes there can be errors in recording the blood pressure value as well. So systolic blood pressure 90 millimeter of mercury or lesser, that's an absolute contraindication for giving nitrates to the patient. Why we are emphasizing that is because traditionally what happens is that your nursing staff would also be thinking that nitrates is to be given to everybody. But what you have to take into consideration is inferior wall MI / hypotension present, nitrates are to be withheld. In fact, inferior wall MI, because it is having hypotension, that's the only MI where you give IV fluids to the patient. So that's again a question that they said, like inferior wall MI, and the questions mentioned blood pressure value of 80. And he said, what is the first intervention? So you would give IV fluids. Now you would never ever see IV fluids being given to any patient of MI, right? Anterior wall MI, there's a pulmonary edema, right? So if I give IV fluid, it will worsen the pulmonary edema component. But in inferior wall MI, we will be giving IV fluid to the patient. So I'll just add that word here to say that especially if a question mentions inferior wall MI beginning with the I, then IV fluids in this particular case would be, though it's like playing with fire. You're giving fluids to a guy with heart failure because ultimately inferior wall MI, right ventricle is damaged. But you're taking a chance, right? What I mean by taking a chance is you are trying to operate the heart on Frank-Starling law. When you'll give IV fluids, you'll stretch the myocardium and you will try to increase the contractility of the right ventricle. And if you increase the contractility of the right ventricle, more blood will be going to the left side. So that will help you in increasing blood pressure in this patient of inferior wall MI, where I said I'll use Frank-Starling law. I'll increase the output of the right ventricle so that more blood goes to left. And heart is a machine. If you improve the input, then the output part will improve. Additional point which we would like to also mention is a word of caution with respect to beta blockers, that inferior wall MI usually has bradycardia associated. Because of bradycardia, which would be heart rate less than 60, this would again be a question that when would beta blockers not be given. So though we were like praising beta blockers that they cause a substantial reduction in mortality by reducing oxygen consumption of the heart, decreasing the size of the infarct, but decreasing the progression of the infarct or the infarct expansion as said, but we would not be giving it in cases of inferior wall MI. So those points have to be remembered, especially with respect to nitrates and beta blockers primarily. And then as far as anticoagulants is concerned, what I would like to add to what Sir has already told you beautifully is that if a person is having anterior wall MI which is causing a LV aneurysm, then aneurysm would imply that there would be a damaged heart, and that damaged heart will not be able to generate force. So every blood in our body should always be in motion, right? If the blood is exhibiting a stasis, because aneurysm is a part of the damaged part of the heart, so it will not be able to generate force. So you have stasis, you have less movement of the blood, and that can again trigger clots, and this could be a disaster in making, because these clots could then go in the brain into the brain of the patient, resulting in development of embolic stroke. So that's another indication for giving anticoagulants to this patient. That would be warfarin on a lifelong basis. And giving warfarin on a long-term basis is not a joke, because that if there's an overdosage, right, half the time the chemist will say this brand is not available. Warfarin is something where you have to insist that whatever brand you will write, the same brand, the same strength has to be taken by a patient, because lots of time different brands would be having different bioavailability. And I think, sir, you would agree to that a lot of time because the sales targets have to be met, so the influence would be such that the chemist might swap it for a different strength of a tablet, which may be double strength, and that could result in development of a brain hemorrhage. Question for you guys at the moment, please comment in the chat box. Warfarin toxicity with brain hemorrhage, what is the antidote? We'll wait for your answers. We'll give you the answer in next 1 minute. Warfarin toxicity with the intracranial hemorrhage, what is the treatment that would be given to the patient? And meanwhile, what I'll speak about is two aspects, that would be asystole and ventricular tachycardia and ventricular fibrillation. This is going to contribute to SCD, sudden cardiac death in a patient. Definition of sudden would be death within 1 hour of onset of cardiac symptoms. This is itself a question that has been asked. What do you mean by the word sudden cardiac death? It is within 1 hour of onset of cardiac symptoms that the patient is no more. Looks very shocking, right? When patient was telling me, I'm having chest pain, he was having that sweating, he's having that, like he's trying to signal with his hand that I'm not getting enough breath because maybe the pulmonary edema component is setting in. And within 1 hour of cardiac symptoms, this chap would be no more because of ventricular fibrillation or pulseless ventricular tachycardia. So we need to defibrillate the patient. In the MCQ, they will be mention of cardioversion as well as defibrillation. You're aware that cardioversion and defibrillation are not same. In cardioversion, we are giving a synchronized DC shock in sync with the R wave, but in ventricular fibrillation, there is no R wave. So it's a defibrillation that would be given. And additionally, the drugs that would be used during defibrillation would be epinephrine as well as amiodarone. Amiodarone would be like 300 milligram that would be given. Though, why are these drugs given? Again, that's a common query. And like one of the reasons why we give these drugs is that they increase the responsiveness to the electroshock. Reason for giving drugs in ventricular fibrillation. The query is, why do you give epinephrine in ventricular fibrillation? The reason is, the rationale is that they increase the responsiveness of the electroshock or the DC shock that would be given subsequently. In asystole, obviously, I need to get the normal sinus rhythm back. So we will be giving epinephrine to the patient. Do remember that asystole is a non-shockable rhythm. There is no role of DC shock in a flatline ECG. Even in shows like Grey's Anatomy, etc., no, they'll show like this, that doctor is giving DC shock on a flatline. It doesn't work. So DC shock is not given in flatline ECG, but it would be epinephrine. That would be the main treatment that would be given, 1 milligram. 1:10,000 dilution that has to be given. And like when you dilute it to 10 ml, no, the entire 10 ml has to be given, because if we give only limited amount, then the drug will never reach the heart. So it's the entire 10 ml that is present in the syringe that has to be delivered to get the heart to get back into motion again and establish normal sinus rhythm. And most of the time with repeated shots of adrenaline, what happens is that we convert a flatline ECG into ventricular fibrillation. The rationale for giving epinephrine is it converts the flatline ECG into ventricular fibrillation. And once that happens, this was a flatline. I was giving repeated shots of epinephrine, first shot, maybe a second shot, maybe a third shot, CPR is going on. And then magically, it may happen, may not happen. But if it happens, what you are going to notice is magic happening. What I mean by magic is not very happy thing. It's a ventricular fibrillation, but you have converted a non-shockable rhythm into shockable. And that's the rationale why we can now give a DC shock to the patient. So these are like two, I would say, dangerous emergencies that can be seen in the very first hour of onset of MI. And that is one of the reasons why we have primarily discussed the topic. As far as the remaining two aspects are concerned, atrial fibrillation, acute heart failure, I would request sir to provide inputs with respect to the drugs that would be used for medical management of these patients, because most of the questions that come on the atrial fibrillation part, a cardiogenic shock would be like pharmacology oriented.
So we know that now that ventricular fibrillation is a very dangerous thing. It can lead to sudden cardiac death because ventricle is responsible for the cardiac output. What about atria? Sir, atria is above. Atria is not responsible for cardiac output. The blood which comes to the atria itself goes to the ventricle through gravity. So remember, AF or atrial fibrillation is not a dangerous thing. But imagine if these atrial impulses, they reach to the ventricle. Don't you think AF can lead to VF and now it can lead to sudden cardiac death? So the logical treatment of AF is to prevent VF. And how we can prevent VF? All the impulses from atria, they comes to ventricle through AV node. So in the treatment of SVT or atrial fibrillation, we give a drug which blocked AV node. And we can remember this thing with the mnemonic ABC. So in cases of VF, we have to block AV node. Now, if this SVT is a typical type PSVT, in PSVT, paroxysmal supraventricular tachycardia, we have to give adenosine. And for long-term maintenance of any SVT, we can block AV node by giving beta blockers. But the problem is beta blockers, we know they are contraindicated in asthma. So if a question comes, SVT in asthma, instead of beta blocker, give calcium channel blockers like verapamil. So this is how we can prevent VF in a patient of AF. Now what about acute heart failure? Acute heart failure means sudden fall in cardiac output because the force of the contraction is very poor, which is also known as cardiogenic shock. So in cases of acute heart failure, don't you think we have to increase force of contraction? The drugs that increase force of contraction, they are known as inotropic drugs. And these inotropic drugs, they will stimulate beta 1 receptor on heart. So which drug to be given? So remember, if there is only and only cardiogenic shock, we prefer to give dobutamine, because dobutamine is a drug which stimulates beta 1 receptor. But if this cardiogenic shock is associated with hypotension, that means systolic blood pressure is less than 90, then prefer to give norepinephrine. Now, why norepinephrine? Because norepinephrine stimulates beta 1, but it also stimulates alpha 1 receptor. Alpha 1 receptor leads to vasoconstriction, which will increase blood pressure as well. And if the third question comes, if this cardiogenic shock is leading to acute renal failure or oliguria, so ARF or oliguria, in this case, we prefer to start dopamine, because dopamine acts on beta 1 plus D1 receptor. So dopamine receptors, they produce vasodilation in kidney, increase GFR, that means it increases urine production. So these are the respective drug of choice if a patient of cardiogenic shock comes to you. So we have now treated the complications which are usually seen in acute attack of MI. Now let's talk about the definitive treatment of MI. So in definitive treatment of MI, logical should be the coronary arteries were blocked. So we have to again open the coronary artery and again maintain or restore the blood supply, which we call it as reperfusion therapy. That means opening of coronary artery to maintain blood supply. Now there are two methods of opening coronary artery. The first method is we can give drugs which will remove this thrombus. So these drugs are known as thrombolytics, which are also known as fibrinolytics. And in this case, thrombolytics, you will find many drugs, many famous drugs like streptokinase, L-tiplase, tenecteplase. So these are the various drugs in thrombolytics. The second thing what we can do is we can do PCI, that is percutaneous coronary intervention. In simple word, we can write for a moment as balloon angioplasty. We can put a probe and this probe will have a balloon which will open this coronary artery and remove the thrombus. Now the choice of reperfusion therapy depends upon the type of MI. Remember, risk versus benefit. Thrombolytic drugs, they have a benefit. They can be given immediately without wasting any time. PCI will take a lot of time. But the disadvantage of thrombolytics is they can not just remove thrombus in coronary artery, they can remove thrombus anywhere in the body and they can start acute fatal internal bleeding and the patient may die suddenly. And in this respect, PCI is much more safer option we have. So the question is, which therapy to be used in which case? Remember, in unstable angina and non-ST elevated MI, the first reason is they don't have such a high chances of mortality as compared to STEMI. So we don't give thrombolytic drugs. In cases of unstable angina and NSTEMI, thrombolytics like streptokinase, tenecteplase, they are only and only given in ST elevated MI, which has high chances of sudden death, and we cannot afford to waste time. What about PCI? PCI is much more safer option. PCI can be done in all three cases. So this is how you should remember. Now the point is, what is the ideal time of doing reperfusion therapy or opening of coronary artery? Ideally, it should be done as early as possible, but it should be done within 12 hours of MI. Now, imagine a patient is having MI at home. He's coming through a car, he will come to your emergency. It will waste a lot of time. So as the patient comes to your door at the hospital, you will not waste time. So thrombolytics must be given within 30 minutes. As the patient arrives, let's call it as door to needle time. While PCI must be done within 90 minutes, it is known as door to balloon time. Now you have definitely treated the patient of MI. Now send the patient back home and put the patient on certain medication so that in future, and again, the chance of recurrence of MI can be reduced. So this type of prevention or prophylaxis, we call it as secondary prophylaxis to prevent another attack. So the main thing is do lifestyle modification. In lifestyle modification, remember low sodium diet. Fish, I think, as the sir will also agree, contains omega-3 fatty acids, reduces lipid level, direct cardioprotective effect. Now we have to protect heart, and we know two drugs which are cardioprotective, ACE inhibitor and beta blocker, are given. For a long term, dual antiplatelet therapy, same. We combine aspirin with clopidogrel and other grel-like drug like prasugrel. Then we have to control the risk factor for MI like hypertension, diabetes and dyslipidemia. For hypertension, yes, ACE inhibitors can take care of it. For diabetes, we give metformin and other hypoglycemic agent. And if the patient is type 1 diabetic, we always start insulin in that. For dyslipidemia, we maintain the patient on statins, which we just discussed. And if the triglyceride levels are also high, we add other hypolipidemic agents like fibrates. So this is all we manage about MI. So let's test your knowledge now. Let's solve certain MCQ and see how much you have understood.
Okay, so by this time, I think you would have commented regarding what's the treatment for warfarin toxicity with brain hemorrhage, and your answer would be given as PCC, that is prothrombin complex concentrate. Vitamin K would not be a good answer because it will take some time to add. Fresh frozen plasma is frozen, right? It's stored at minus 20 degrees Celsius. So it's like, literally like a big block of ice. We can't give it immediately, so we need to let it thaw. And that's the reason why we will give ready-made clotting factors. That's called as PCC, that is prothrombin complex concentrate. You'll also notice that in a couple of MCQs, instead of saying the word door to balloon time, they might be saying first medical contact to device time. Like in US, they have the 911 number. So ambulance will reach the home within 5 minutes of the person. So the word used is first medical contact when the call came to the. In India, no, like this would not be practical. I mean, you open Google Maps and you'll find that, the distance is 5 kilometers and it will take 1.5 hours to transmit that distance on a busy Gurgaon road or the airport access road. It's crazy traffic. But from an American perspective, because we are following the AHA guidelines, he will say first medical contact to device time, and the answer would be 90 minutes. This would be valid for a STEMI. But if he talks about non-ST elevation MI, then in non-ST elevation MI in high-risk cases, the PCI should be done within 120 minutes. Do remember this fact. For STEMI, this would be 90 minutes. For non-ST elevation MI is 120 minutes. And ideally, whenever we are getting a patient who's having ST elevation MI, our first preference in a situation where cath lab facility is not available, we should tell and inform the relatives that they can take to a cath lab equipped hospital. In case the transport time for a cath lab equipped hospital is less than 120 minutes, again 120 minutes coming in the discussion, but this is valid for STEMI. In case a STEMI patient comes to, let me say, a place where in the periphery where cath lab facility is not available, if the transit time to a tertiary care hospital will be less than 120 minutes, we need to transport the patient in a equipped ambulance. Doctor should be accompanying that so that the treatment in the form of PCI can be done. But if the transit time would be more than 120 minutes, never a problem. Then you can start managing the patient with thrombolysis. So thrombolysis is always a backup approach. That's the the main concept that I wanted to say. And the target LDL values would be like for secondary prevention would be value less than 55. Anybody who's a diabetic, atherosclerotic cardiovascular disease, extremely high risk. So we need to keep the target LDL values as less than 55 with high intensity statins. Now, drug that is not given in non-ST elevation MI has already been emphasized. That would be the reason which we mentioned right in the beginning. Non-STEMI ACS is going to be a platelet-rich clot, so no benefit of thrombolytic drugs. And in case we are giving tenecteplase, that would be given as a bolus. So the time that we should be giving tenecteplase to the patient, the door to needle time should be kept under 30 minutes as we discussed. And then an incorrect prescription with respect to acute STEMI would be that we have to give like high intensity statins, right? So that would be like rosuvastatin is like 2 lesser dose that is being administered. So these are like the technical aspects, guys, which we would like you to remember for this topic. Thank you so much for hearing us out.
Thank you very much.